Thanks so much, everyone. Again, I'm Dr. Katie Beard. It's nice to meet everyone. This conversation we're about to have dives into one of the most defining aspects of women's health, which is hormones. Whether it's puberty, pregnancy, perimenopause, or menopause, hormones influence not just migraine, but mood, sleep, and metabolism. Today, we're going to look at how these transitions affect the body and how women can navigate them with confidence and with clarity. So starting with Dr. Shepard. Where's Dr. Shepard? Is she gonna come up on the screen? Sorry? She's not? Oh, okay. Okay, so, okay. Well, Dr. Mays and Dr. Siriani, could one of you maybe answer how women's hormones change across the lifetime?
Yes, I guess I can start. So I'm going to approach this as a headache specialist. And so when I entered the field of headache medicine, one of my mentors, Dr. Nunu Zhang out at Stanford, she likes to use this red Solo cup analogy to explain why migraine happens. And I like to share this with my patients, and I'll share this with you as well. So think about a red Solo cup that you sit with. A third of that cup is going to be filled with genetics. We know that migraine has a strong genetic predisposition. You can't fight with your parents on what you inherit, right? Then the second third of the cup is going to be filled with extrinsic factors. So whether that's lifestyle factors that can impact headache presentation that we heard from the previous panel, that gets your cup to a 2/3 full. And then when we think about how women are affected by migraine at a much higher rate than men, we think about hormones. And if we factor in those hormones, then your red Solo cup, that last third, is going to be filled to the brim and almost overflow and cause and trigger migraine attack. Now, I know that's a pretty simplified description of what is a super complicated neurobiochemical disease, but I think it's a great starting point to discuss how we would expect migraine in particular to evolve over a woman's lifetime. So specifically when we're thinking about menarche, so the period of time when most of us women start to develop having our menstrual cycles, that's when we see a shift as far as migraine frequency and peak prevalence starting to increase in comparison to men. And why is that? There's been some curious studies looking specifically at patients who experience migraine and their estrogen levels with a regular menstrual cycle versus patients with migraine and a regular menstrual cycle. And we found that patients with migraine in a regular menstrual cycle actually have higher baseline estrogen levels in comparison to those patients who don't have migraine. So we're already starting to think that there is some estrogen component to migraine. So as we go on throughout life, especially into adulthood, we break down migraine based on menstrual association. So about 1/4 of women who experience migraine have a strong menstrual association, and that can look like a variety of different things. So there is something called pure menstrual migraine, where migraine attacks are specifically triggered around one's menstrual cycle. And then there's menstrually associated migraine, where this occurs. There can be an association around the menstrual cycle, but then breakthrough migraine attacks can also happen throughout the rest of the hormonal cycle. And so we can see this variability shift throughout one's life, and specifically we have some theories as to why this happens. So estrogen withdrawal in particular could contribute, but we also are questioning, are there higher baseline levels of other migraine-specific neuroinflammatory markers and proteins? Specifically, this conversation we'll talk a little bit later about CGRP. So patients with migraine and menstrual migraine actually have a baseline higher level of CGRP, which we think could also impact a migraine presentation. So we expect the life cycle as far as the menstrually associated migraine to change, and we'll talk about some treatment options here in a bit. But one passion that I have in particular is how do we address migraine in pregnancy. As you can imagine, there are not many treatments, not many things that we can think about using in patients who are pregnant. So in general, pregnancy is protective against migraine. And so for a vast majority of patients, migraine gets better, particularly in that second and third trimester. But we know migraine is not one size fits all, and that's not always the case. And thankfully nowadays we do have some options that are available for treatment. But I'll pause there as far as what to expect with pregnancy during migraine. I'll let Dr. Siriani address.
Yeah, thank you so much, Dr. Mays, for answering that. I think you're jumping into our next question. Dr. Siriani, do you want to talk about how migraine changes with hormonal changes later in life, and maybe answer the question that I think so many of us have, which is, will migraine go away with menopause?
Yeah, so first let's just define what actually menopause is. So menopause is when you stop having your menstrual periods, but first there's a period called perimenopause that's usually 1 to 2 years where your menstrual cycle becomes more irregular. You can start to get a lot of the symptoms that we tend to think of as being menopause symptoms, like hot flashes, night sweats, anxiety, irritability, insomnia, all of these kind of fun things that happen around what a lot of people call the transition. And then menopause is when you've actually had your last menstrual period and you have stopped menstruating for at least a year. So there are a lot of hormonal fluctuations that happen in that perimenopausal period that can be major headache triggers for a lot of people who experienced migraine. So as we already kind of heard a little bit with the menstrual cycle, one of the really major triggers for migraine in a lot of women is a sudden drop in estrogen. So that's something that happens right at the start of your period. And in the period of perimenopause, your cycles become more kind of erratic. They're less predictable. They can be closer together sometimes and then further apart at other times. You can bleed for longer periods. You can get kind of a weirdly short one. And many people will experience kind of more extreme fluctuations in hormone levels, including estrogen. So for many women, perimenopause is actually a time when headaches worsen because those estrogen fluctuations are more extreme and they're kind of more unpredictable. And then the question that we do get very often is, well, will my headaches go away after menopause? Because then you're no longer experiencing all of these huge estrogen fluctuations. It sort of makes sense that headaches should stop after menopause or at least get better. And that is true for a large number of women. Many women who have migraine do find that their headaches become easier to manage or sometimes even go away in menopause, but that's just not true for everyone. And I'm thinking about a patient that I had a few years ago who, at that time, I think was probably about 2 years postmenopausal. And she came to see me because she was really worried that there was something very, very wrong with her. Not because her headaches had changed, which is usually why people worry that something's wrong, but because her headaches had not changed. So she had been experiencing migraine since she was in her early teens. It had been something lifelong for her. It worsened in her 40s when she was in perimenopause. And she kept talking to her primary care doctor about her headaches. My headaches are getting worse. They're getting worse. There's something happening. What can we do about this? And her doctor kept telling her, don't worry about your headaches too much because as soon as you get to menopause, they're going to be gone. And this was something that she really put a lot of hope into, and then she hit menopause, and that didn't happen. And because her doctor had told her that she could expect her headaches to go away with menopause, she really worried that there must be something terribly wrong with her. And she just kind of assumed that there must be something really serious or that she was somehow kind of broken in some way. And I reassured her that that's not the case at all, that there are plenty of women with migraine who continue to experience their headaches even into menopause. Sometimes their headaches stay about the same. Sometimes they get better. Sometimes they get worse. Sometimes they change in different ways. They can get new symptoms. Sometimes they lose symptoms, so they can become more manageable. But there's really a huge spectrum of what can happen post-menopause. And it's really kind of unfortunate, I think, that a lot of women have been told, don't worry too much about it. When you get to menopause, this will be behind you, because that's just not always the case. I was also especially upset to hear this story because even if her headaches had gotten better in menopause, why wouldn't you do something about it in perimenopause? I don't understand why she wasn't offered treatment then instead of just being told, don't worry about it too much, you just have to tough it out for 2 years. So my take home from that story is, if someone is not listening to you about your headaches, if your doctor is uninterested in your headaches or tells you that they're not really as big a deal as you think they are, first of all, get a new doctor. And second, it can be really helpful to attend events like this and connect with other women to hear what their stories are like, because you may discover that your story is not as rare and uncommon as you thought it was. So one thing that we see very frequently with menopause is that headaches do improve. So it's totally reasonable to put some hope in that, but there are also some people who experience a worsening. We don't totally understand why there's this broad of a spectrum, but basically hormone can't be the only reason, is essentially what it is. The relationship between estrogen and migraine is pretty complicated, and to continue from the red Solo cup analogy, there's a lot of other stuff that goes into migraine. So just going from the medical literature, there's some kind of interesting facts about estrogen and migraine that can kind of point us in the right direction maybe of what this relationship is. There's research that shows that estrogen kind of primes some of the pain receptors in certain parts of the brain to make you more pain responsive. There's also research that shows that lower levels of estrogen can be pain protective. But then there are also some women who experience no real change with their headaches with their menstrual cycle, so they don't seem to have that strong of a hormonal connection. There are some women who develop migraine for the first time post-menopause. So it can't be that simple either, that it's just a change in estrogen changes your headaches. There's something much more complicated at play that we're still learning about. But generally speaking, if you have hormonally affected headaches, it's the drop in estrogen that is most critical for triggering headaches. And so that's probably why perimenopause is this period of kind of turmoil for migraine, because you're seeing these really huge fluctuations in estrogen, and why many people find that their headaches improve post-menopause because estrogen is now at a low, steady level, so you're not getting that trigger. There can be some other factors post-menopause that might impact headache as well. Some of the most common headache triggers are things like loss of sleep. Well, a really common problem that people experience in menopause is insomnia. We know that things like anxiety and depression can have a negative impact on migraine. Those are also more common in menopause. So it's probably more than just hormones itself causing these changes. There may be an increased experience of certain triggers postmenopausally. That might be part of the reason why some women experience a worsening of their headaches in menopause. So I think it's really important to understand that there's a spectrum. There isn't a normal response to being in menopause or being in perimenopause, and this should be an ongoing conversation with your doctor about if you are experiencing changes that are concerning or if the changes that you're experiencing are part of that normal spectrum.
Thank you so much. Those are really thoughtful answers for something that I know is a universal experience for all women with migraine, so thank you. Moving on, let's talk about treatment options, specifically starting with treatment options for migraine in pregnancy, menarche, patients with menstrual migraine. What are some things that are available to them?
Absolutely. Whew. The good news is we have lots of options. I'm like, where do I want to start with this? Okay, so if I were to speak with a patient who is planning on conceiving, I would educate them about really this two-pronged approach to headache care that we use. There's preventive treatment, and then there's acute treatment. So I want you to remember that preventive treatment is almost like we're building a fence around you, right? What's the purpose of a fence? Keep something in or keep something out. And in this case, preventive therapy, the goal is to reduce the overall frequency of your headaches and also the intensity of your headaches. So thankfully, we incorporate preventive therapy in just based on the overall headache burden and how much headache is impacting your overall quality of life. We do have some guiding principles to say that a certain number of days per month affected by migraine should warrant more aggressive preventive therapy, but it truly depends on the individual patient and what you'd like to see as part of your management plan. So if you're trying to conceive and you're thinking of preventive therapies because your migraine burden, unfortunately, is very high at baseline, we do have pharmacologic and non-pharmacologic options that are available. So some of the routine preventive therapies that we use for migraine not in pregnancy, we can use as well. So one example is actually a blood pressure medication that we use at smaller doses. That one's called propranolol. If you're one that's like, I really prefer not to take medications during pregnancy, totally reasonable. We have some great neuromodulation devices that are out that we can use preventively. So one example is the Nervio device, and so patients can use that every
Recording
other day.
in progress.
Every other day for migraine prevention, and can also be used for acute treatment. We have more localized procedures that we can consider as well, just risk-benefit discussion on involving the individual patient. So we can bring patients in for prophylactic nerve blocks. So we bathe the nerves that may be involved in migraine with a little bit of local anesthetic medication, and usually that can get through. So it truly depends on what the patient's plan is, how aggressively they'd like to manage their migraine, especially from a preventive standpoint. Now, with pregnancy, for acute treatments, our options are a little bit more limited. So one of our old gold standards was to use Tylenol. I hate to use Tylenol and acetaminophen nowadays. I know that's a different topic for different reasons. But Tylenol can still be used on an as-needed basis. But if you notice that you're using your Tylenol more frequently and your headache frequency is increasing, that's not necessarily a Tylenol problem or an acute treatment problem. It's actually a prevention problem. And that's when we need to talk about, hey, how do we bolster your fence to try to reduce the overall headache frequency? We also can use those neuromodulation devices as well. We have found that those have been safe to use during pregnancy as well as in the postpartum period and lactation. So that's been quite encouraging as well. Then if we're still having really high headache burden, onabotulinum toxin, so Botox has been around for a long time for the indication of chronic migraine. I see some heads nodding, so people are familiar with that. And so while we don't have any randomized control trials looking at Botox in pregnancy, there is some safety data that a lot of us headache specialists are feeling more comfortable with using Botox, especially in someone who's been getting Botox previously, continuing that during pregnancy as well in the postpartum period. Then in the postpartum period as well, we can consider some additional as-needed medications, so I can start adding back, in pregnancy we can also use certain triptans, so if you've been someone who's used triptan before, certain triptans we can continue, and also in the postpartum period. And then for those patients who have been on Ubrelvy and Nurtec, this has been exciting. Some of our preliminary data has shown that there's been really small relative infant dose that the baby gets from what the mother takes in. And so we think that those can be added back in the postpartum period as well. So as you hear, there are thankfully plenty of options. You don't have to be without, you don't have to suffer with migraine during pregnancy. But then hopefully also you're one of the patients that maybe migraine does improve during pregnancy like we expect for many patients. But if that's not the case, we definitely have some options that are available.
Thank you so much, Dr. Mays. And Dr. Shepard, thank you for joining us. Hi.
Hi, how are you?
Hi. We're just talking about the different treatment options available to women at different stages of their life. Dr. Siriani, do you want to go next about some treatment options or strategies for patients with menstrual migraine?
Sure. So for menstrual migraine in particular, there's one kind of special treatment option that we have, which we call mini prophylaxis. And this is where rather than taking a preventive medication every day, or if you're doing like a monthly injection or doing Botox every 3 months, you take something that normally we use purely on an as-needed basis, but you take it every day for several days in a row around the time of your period when you're most prone to getting headaches. in order to do this, you do need to have fairly predictable cycles, and you need to be able to estimate within a couple of days when you're most likely to experience menstrual migraine. But if you can do that, if you can take a pretty decent guess on the calendar of when your menstrual headaches are going to start, you can begin taking mini prophylaxis 1 or 2 days before that, continue it for 3 to 7 days, kind of depending on how long you tend to be prone to headaches, and that may help just stop them before they even start. So to do this, we use medicines that are normally prescribed on an as-needed basis that have a long half-life, meaning they stick around in your body for a while. So this is certain triptans, like the most common one that we use is frovatriptan, which has a really long half-life. So you can take that every day, and it just kind of covers you for that period of time while you're taking it. Sometimes long-acting NSAIDs like naproxen can be helpful. And then some of the newer medications like rimegepant, which has a long half-life as well, can be used. And at Jefferson, we actually have a study going on right now where we are recruiting women who have menstrual migraine, who have relatively predictable cycles, who would enroll in this study and use rimegepant as mini prophylaxis every month for 6 cycles. You would be assigned to either rimegepant or a placebo, and then after that, there's an open label part of the study where you know you're getting the real medication, and you can continue on that. So there are a number of different treatment options in this mini prophylaxis category. If your cycles are not predictable enough to do that, that may not be a feasible option. Sometimes that might be a reason to decide to go on a hormonal contraceptive pill, because that gives you more predictability, and some women also find that their menstrual migraine attacks are easier to manage on a low-dose estrogen oral contraceptive pill, because the drop in estrogen that you're experiencing is smaller when you're on a lower dose of estrogen, so that's also a strategy that can be used. If you also tend to get headaches kind of sprinkled throughout the month, you may be better off just focusing on preventive care overall, taking some kind of preventive medication the entire month. But you might still have attacks during your menstrual cycle that are harder to treat, that last longer. So you might want to have a few different as-needed options that you can kind of throw in all at once and treat more aggressively. Sometimes that's the best strategy to take.
Thank you so much, Dr. Siriani. It's so exciting also to hear about that study that we're looking to gain more treatment options for patients with menstrual migraine, so thank you.
Call us if you're interested in doing that.
Please. Dr. Shepard, so nice to see you. We're going to move on to you for the next 4 questions, if that's okay.
Great.
Rapid fire. Could you explain to us what hormone replacement therapy, or HRT, really is?
Yeah, hormone therapy is very different to what we used to think about hormone therapy. And I think the best way to preface hormone therapy is that just we were talking about menstrual migraines and the fluctuations that you see in estrogen, which can really create havoc for people who have menstrual migraines. The same thing typically is what we see in the perimenopausal, menopausal phase. So the difference is that this period can really last anywhere from 3 years to maybe even 10 years. And so because it's so kind of vast as far as the time frame and duration, this is why it is important for us to understand how hormone therapy can be beneficial in changing some of the fluctuations that you see in the perimenopausal phase. Now, when we typically look at hormone shifts between perimenopause, which is still when you have your cycle, but you're starting to see those fluctuations because of the estrogen decline, but also the estrogen and progesterone ratios. So it's really those ratios in how they fluctuate and the severity of those fluctuations during the perimenopausal phase that can create some of the symptoms that women typically will have. And so the severities and intensities of those are going to be different for every woman. So that's why it can be somewhat a little bit challenging to, one, understand the benefit of hormone therapy, because we're really trying to decrease those fluctuations. And that's why migraines actually play into the perimenopausal experience, because of those fluctuations. So the goal with hormone therapy is to decrease those fluctuations and therefore offsetting some of the symptoms that women will experience during that time frame.
Thank you so much for explaining that, Dr. Shepard. Could you go on to explain who is a candidate for HRT and what are some contraindications to getting HRT?
Yeah, I always actually start with the list of who is a candidate because from what we typically understand when we think of WHI, which really was 20 years ago, and really how it created havoc in understanding the beauty of what hormone therapy can provide, but also on the side of who's a candidate, that's where we start to see more people actually start to have anxiety, concern, worry that they are not a candidate or that if they take it, something bad is going to happen. So, in the research that we know, both from the WHI and studies that have been done since then, most women are actually more of a candidate than not. So, when we go to contraindications, that really is going to be patients or women who have had a personal history of some clot disorder or a very high genetic predisposition to a clot disorder. So that doesn't necessarily mean if you have hypertension that you may have a clot that you can't take hormone therapy. It really is with that personal history. Now, when we switch over to breast cancer, this is really where we get into a very deep conversation that can be controversial because there is a tendency to believe that estrogen causes breast cancer. But that's actually not what the WHI found. They actually found that estrogen was protective against breast cancer. It was the progestin and the synthetic progestin that was used that really increased that risk of breast cancer, which really was not significant. So when we think of who cannot take it from a breast cancer standpoint, are patients who have a personal history or have been genetically diagnosed with estrogen receptor positive cancers. So that even eliminates people who might have a family history of a breast cancer that is not genetically predispositioned. So the breast cancer, I feel like that category really needs a nuanced conversation, but most women who may have had a family history of some sort of breast cancer does not necessarily exclude them from considering hormone therapy. So it really should be looked at what are the contraindications, which that list really is very small, to moving over into more of a conversation of considerations. And once we enter in the conversation more from a consideration standpoint, then you actually begin to see that more women actually are a candidate for hormone therapy than not.
Thank you so much for that in-depth view. That's really like refreshing, I think, to hear it framed in that way. Next, could you go into the specific types of medications that are available or even supplements to treat these symptoms of menopause?
Yeah, for the symptoms of menopause, obviously, when we talk about hormone therapy, if you look at the fundamental reason why women are having these symptoms, it has to do with those estrogen and progesterone ratios. So the goal is to how do we change those ratios to more of a level set where women are not having these symptoms. So hormone therapy is probably going to be one of the best ways to resolve it. Now that doesn't mean, and I really say this, emphatically, that if you take hormones or you choose not to, that doesn't mean that that's a bad thing. And so outside of that, when we're looking at options for some of the symptoms that women experience during perimenopause and menopause can be still the ones that they've had in the past when we think of hot flashes or vasomotor symptoms rather, hot flashes and night sweats, you still can consider an SSRI. Now, when we look at effectiveness, are we going to get as much efficacy for resolution of those symptoms with the SSRI versus hormone therapy? Not necessarily, but it's still an option. And then there are medications that have come out recently that are looking at vasomotor symptom resolution without having to provide from a hormone standpoint. And that's where we consider the hormones that are located, the receptors rather, that are located in the brain that have to do with hot flashes and night sweats. And that's where they actually focus the actual category of these medications is to focus on that rather than the estrogen and progesterone. And then I always say for women going through, this time frame in their life is to always look at lifestyle factors. Those are probably one of the best things that you can look at, that you can do every day in your life that actually have been shown to decrease some of the symptoms that women go through. And that's what we kind of put in the bucket of complementary alternative forms of resolution, medication, treatment that can be with increasing your working out, your exercise, even looking at yoga data and acupuncture, they have shown data that shows that it can resolve and decrease some of the symptoms that women go through. So I always say it can be this working machine or this puzzle that you're putting together for yourself individually that can work for each and every person differently. But knowing more and having more to pull from a toolbox, to me, is one of the best ways that you can approach. And even if you do start hormone therapy, I think that you have the ability to think of different form factors, how you receive the hormone therapy. And then the other beautiful thing is that even if you don't consider it, is to still have the conversation, because later you can consider it as something that you want to start.
So amazing. Thank you so much. And that leads us right into our next question. Who should women be turning to for help in these situations? Certainly their OBGYN. Is there anybody else that they should be going to if they're looking for help with these types of symptoms?
Yeah, where we have come now, I feel that there still is hesitancy, even in the medical field, with what is the best tool. And hormones still are very controversial. How do we prescribe it? What are the best options? And so we do have categories of what we call menopause certified practitioners, which can range anywhere from OBGYNs to family practice who have undergone this training, even to NPs and PAs. And so it really is out of the scope of how we used to think about perimenopause and menopause, and only an OBGYN can consider it. So I do believe that there's more specialties that actually look at how to deal with perimenopause and menopause. But the Menopause Society online has a list of certified providers that really have looked at midlife and menopause medicine specifically, and that's a great way to start for people who are looking for that.
Thank you so much. I feel like I'm learning so much. I don't know about you guys, but that was so helpful and informative. Thank you so much. All right, so we're going to move on to the next question. For all three of you, Dr. Mays-Siriani and Dr. Shepard, a very important question that so many of us want to know. I think that you had already touched on this, Dr. Shepard, but can women with migraine use HRT? Can women with migraine use oral contraceptives? I know that these are kind of two separate questions. Dr. Mays, do you want to start?
Sure. So, of course, this gets a little bit more complicated. I think Dr. Nahas highlighted earlier that migraine, being such a complicated disease, affects many systems in the body. And we know that about 30% of patients who experience migraine experience something called migraine with aura. And so aura and migraine are independent risk factors for stroke. Very, very, very tiny risk, but it's not negligible. And so if we're considering adding estrogen on top of that, then again, that's going to be a risk-benefits discussion that we would have to discuss in detail. And so in general, across headache medicine, our recommendations are if you experience migraine with aura, we tend to avoid estrogen therapies. However, I think, as Dr. Shepard highlighted, I think as we are learning more about different types of estrogen to administer, different routes of estrogen, the dosages, I think those recommendations are probably going to change. I don't have a magic wand to say that, but I think that's going to be evolving with time. But if patients have a history of migraine without aura, I have many patients who are on hormonal supplementation, hormone replacement therapy, oral contraceptives. A lot of them do find it helpful specifically for menstrually associated migraine. So I think this is definitely a reasonable option to consider as part of your comprehensive headache management plan.
Thank you. Dr. Siriani, anything to add?
I'll just say that this is a question that if you asked 10 different headache doctors, you'd probably get 10 slightly different answers. And the research is kind of continuing to evolve on this. We've sort of moved on from the more black and white, if you have aura, you can never take estrogen. There's way more nuance to it than that. Lower doses are probably safe. If you don't have a lot of other vascular risk factors, meaning things that put you at risk for stroke or heart attack, it's likely safe. But this needs to be an ongoing conversation with your doctor. One thing that I think is really important to point out, though, is that many people are incorrectly diagnosed as having aura when they actually don't. So if you're being told by your doctor that you can't go on a hormonal contraceptive pill or HRT because you have aura, first get a clarification of if you actually have aura or not. So I've had patients told that they have migraine with aura because they experience blurry vision during their headaches. And that's a very common symptom that can occur throughout a migraine attack, but isn't actually the same thing as a visual aura. I've had patients who have dizziness because they have vestibular migraine, which is a non-aura kind of symptom of migraine, but they're told that that's an aura symptom, so therefore they can't have estrogen. So first things first, make sure that you actually really have the correct diagnosis. If you've never seen a headache specialist, even if it's just going to be for like a one-time visit to clarify the diagnosis of migraine with aura, start there. And then it's really important that you're kind of going through all of your medical history and your family history with your doctor and really determining how big is your stroke risk really on an individual level. And if you are getting your blood pressure checked regularly, getting your cholesterol monitored, getting your sugar levels monitored, if you have high cholesterol, that you're taking your statin or whatever kind of medication you've been put on regularly, and doing everything that you can to reduce all of those vascular risk factors, then something like HRT may still be an option for you. It's not as black and white as we used to think that it was.
Thank you so much. Dr. Shepard, anything to add from your perspective?
Yeah, absolutely. So I love the migraine discussion because myself, I suffer from migraine. So it's important for me to make sure I understand the data. But when we actually look at the data, it's scarce when we look at migraines with aura, specifically in the menopause kind of transition. And what we're looking for, exactly like was stated, is the risk of stroke. So always approaching the conversation with risk versus benefit. Obviously, with aging, you're going to have differences in risk of stroke just because of age, not necessarily because of the menopausal transition. And when we look at actually a lot of the data with migraine with aura and risk of stroke was actually based on oral contraceptives, which again are a different category than when we think of menopause hormone therapy or HRT, because those risks are actually going to be increased with OCPs and with smoking. And so that's how we have to do risk stratification when I have conversations with hormone replacement therapy and migraine with aura. And what we are seeing is the data started really more to push towards that is not necessarily a contraindication, because the goal of HRT is actually not to get women back up to a significant high level of estrogen and progesterone like we typically see in the reproductive phase, which it's much higher. And then also with OCP is a different type of hormone. So it's different type of hormone, different ratios of estrogen in the actual woman herself. And so when you start to categorize it that way, actually what we start to see is that risk of treating with HRT in women going through menopause, actually that risk starts to decrease because we're using such a low level of hormones. We're really trying to resolve the symptom of menopause rather than increasing risk of comorbidities in women going through this transition. So it's actually a very fascinating conversation that we're starting to see with migraines. And I'm excited to hopefully show that the data will approve or, kind of lean more towards treating women with migraines with aura in the menopausal phase and still being able to get HRT.
Yeah, I definitely agree. Looking forward to the future. For our next question, also for you, Dr. Shepard, for women with migraine who have comorbid gynecologic conditions such as endometriosis and PCOS, what are some treatments that you would recommend with this in mind?
Yeah, the beautiful thing about PCOS and endometriosis, because those are, again, chronic inflammatory, painful often syndromes, is most of those will start to subside as far as those pain syndromes as you start to enter into the perimenopausal phase, because a lot of the conundrum that you feel with these instances has to do with hormone levels. So when we look at treatments, one, if someone is looking for resolution of symptoms in the perimenopausal and menopausal phase, but has conditions of PCOS and endometriosis, I still approach the conversation with risk versus benefit. And typically, specifically with endometriosis, this is where we see estrogen kind of acting as a kind of antagonistic type of part of estrogen, because estrogen is kind of like the wonder drug. It's a golden hormone to me. So in the way that we approach that is, I'm going to relieve your symptom with HRT. You get to decide if this is something you want to even try. Because if the pain actually does not come back because the estrogen levels are not so high to incite inflammation, then it's a win-win. So we have resolution of menopausal symptoms and we don't have the pain returning. And the goal is to find a provider that can actually balance those two and allow a woman to at least consider it, start it if necessary, and then maybe change form factor or decrease the dose if they start to have some of those pain symptoms resolve. PCOS is a little bit different, but that usually has a lot of progesterone ratio issues when we look at PCOS. So that's another consideration that person can still start HRT. But endometriosis in the last 5 years has had medications that are devoted specifically to pain as a GnRH antagonist, and those have worked really well in women who have painful syndromes from endometriosis.
Thank you so much for that in-depth answer. I really appreciate it. Thank you. And now moving on to Dr. Siriani, do you have any recommendations for patients with migraine and other comorbid endocrine conditions, specifically such as thyroid, which I know is so common?
Yeah, so the answer on this is not super clear. The research on the relationship between thyroid dysfunction and most specifically hypothyroidism is usually what's studied, and migraine is kind of all over the place. There are some studies that suggest that having migraine increases your risk of hypothyroidism or vice versa. There are also some studies that say that there is no connection. So we don't really know is the honest answer. But headache can be a presenting symptom of hypothyroidism. So about a third of patients with hypothyroidism may have headaches as part of their initial symptoms. And some people who have migraine and hypothyroidism anecdotally have reported that their headaches have been worse if their hypothyroidism has been undertreated. I can't say that I've seen a lot of like really convincing cases on this, that there's a really tight connection. I think it's probably something that for most people is not that relevant, but there may be some individuals where there is more interplay between their thyroid levels and their headaches. So basically I tell my patients, if you've never had your thyroid level checked, it's reasonable to do it. It's a very easy blood test to do. It's a cheap test to run. And hypothyroidism is quite common in women, especially in middle age. So it probably should be checked at some point in your lifetime anyway, just as a screening test. But don't count on that necessarily holding the key to managing your migraine. Likely what we're seeing is that migraine is very common in women, hypothyroidism is very common in women, so statistically speaking, there are going to be a large number of women who have both, but it's not necessarily that the two are really tightly connected with each other. But we're still learning about this.
Thank you so much for explaining that. For our very last question, I guess, you know, in both of these fields, in OBGYN and also in headache medicine, are there any recent advances in either of these fields that make you, excited or give you hope for a more personalized hormone-based migraine care strategy? Whoever wants to start. Oh, Dr. Shepard, I don't think we can hear you.
I'm muted, yes. I'll give a quick answer. I am really hopeful. I trained 20 years ago in Philadelphia, by the way, and I had migraines, and I suffered through residency with a lot of migraines. And again, the recommendations back then were so different to what we're seeing now. And especially for women going through the perimenopause, menopausal transition, like I am now, fast forward 20 years, it's great to see that we are even having medications outside of hormone and considering if a woman should take or not, that we have advanced even in the migraine category itself. And so I think that that's very promising, especially because women typically tend to suffer from migraines more, is that we're kind of pushing beyond the barriers of what is going to happen already biologically in women with hormones that we can't control. And kind of superimposing or having an overlay of still being able to address a migraine situation because they're so debilitating. So I'm very happy for myself and my patients and women in general, especially because migraines, rank as the second highest cause of disability in the world, and it's often overlooked as a type of disability that people have to go through. And so I'm really excited to see what we're gonna even advance even more in treatments.
Thank you so much. Dr. Mays?
I think I'm most excited about the field of headache medicine in the sense that we are truly understanding the strong interplay between primary headache disorders such as migraine, but all of these other diagnoses that we're highlighting today. And so one clear example that I just thought of from Dr. Shepard, thinking about PCOS and endometriosis, there's some early clinical trials that are looking specifically at CGRP. This has been all the rage with migraine, but we think that there's some shared pathophysiology in these pathways, these pain pathways, especially with endometriosis. So it'd be so nice to start to develop more treatment options that could target multiple symptomatology and multiple disease states. So I'm excited to see what happens with that. But I've also been encouraged by many of my colleagues in headache medicine throughout the country who are working collaboratively with OB-GYN, women's health colleagues, to try to grow integrative women's health centers where you don't feel like you have to go individually to GI over here to talk about women's health issues and gynecology across town and your headache specialist in a different location. There are more integrative centers that are arising, and I know this is an area of interest with me. I work at the Philadelphia VA and I run our Headache Center of Excellence there, and oftentimes women veterans are overlooked when it comes to their women's health challenges, especially with headache. And so we are actually getting some additional funding to grow an integrative center where we have access to gynecology, some of those complementary modalities that we've highlighted, health psychology, so on and so forth. So I'm very excited to see the prospect of what those multidisciplinary centers will look like in the future.
Thank you so much. Dr. Sirianni?
I think it's really exciting to see the amount of research that's being done into women's health issues in general, but in migraine specifically, studies looking at menstrual migraine and the impact of perimenopause and menopause on migraine. Historically, medicine as a whole has left women out of research because our fluctuating hormones make us complicated. And so for the purposes of good, clean data, a lot of research in other fields of medicine was done with only men. And it's actually relatively recent that we have regulations saying that you have to include women in medical studies. Migraine is kind of in a unique position where, because it is more common in women, that's kind of not been as big of a problem in our field, that just by the nature of it being a disease that affects a lot of women, studies tend to have a lot of women enrolled, and sometimes it's actually hard to get men enrolled. Most diseases don't really have that problem. But the fact that there's now so much research being done into things like menstrual migraine, where the complicated hormones are kind of the point, and it's why we need to study it. So I think that's a really exciting thing that's happening in the research side of things.
Thank you so much, Dr. Sirianni, Mays, and Dr. Shepard. This was such an empowering talk. Thank you all so much for being here. I think the biggest takeaway for everyone is that, hormones and women's hormonal health should really be at the center of the conversation, and it sounds like there's some advances in the field that are going to allow us to have more integrated care in the future. So thank you all so much.